Welcome, everyone, to the Society of Thoracic Surgeons Adult Cardiac Surgery Database QI Series webinar for July 16th. We're glad that you were able to join today. We'll start out by giving a welcome and introductions. On the call with me today from the STS, I have Carol Crone, Emily Conrad, Leanne Jones, and Sydney Clinton. So welcome, everyone. Our agenda today will quickly review a few important dates. Then we'll wrap up our QI project, Decreasing Blood Usage, and then we'll move on to introducing our new QI project. So important dates today, the QI series webinar. Next important date, August the 14th, is our monthly webinar. This is a new date. It's been moved from our original date. This will be on a Thursday. We had to move that due to some scheduling conflicts. So the next monthly webinar will be Thursday, August the 14th. August 22nd, Harvest 3 closes. This is surgery dates July 1st, 2022 through June 30th, 2025. Then on August the 26th, we have our Harvest 3 opt-out deadline, and that is now with a time set of 5 p.m. Eastern to get your opt-outs in. September 3rd is the next ACSD monthly webinar. And then finally, to wrap up September, on September 25th and 26th, we'll hopefully see all of you in San Antonio for AQO. Here's a look at the harvest schedule, and just again, Harvest 3 closes August 22nd with an opt-out of August the 26th. And just make sure you're aware, if you need to opt out, you do that before 5 p.m. Eastern on the date that's listed. So AQO, it's really right around the corner. I believe we're 10 weeks out. We're very excited to bring our program to you this year. We'll be in San Antonio, September 25th through 26th. At the Grand Hyatt on the San Antonio Riverwalk. Adult cardiac session, that will be on Friday, September 26th. CHSD and general thoracic will run concurrently on Thursday, September the 25th. Intermax and PDMAX will be virtual only on September 23rd. You can register now from the website by clicking the link on the web page. If you need more information, click on the Learn More here. On this page under Data Manager Guidance, you can find the schedule. You can look at the agenda. There will be information on pricing, hotel information, and you can request a justification letter if you need it for your leadership at your hospitals.
What's the name?
So just a note on pricing. The early bird pricing has been extended until July 31st. I'm not sure if that's noted on the website yet, but just so that you know, you can receive early bird pricing until the 31st of July. All right, so as you know, over the past several months, we've been working on a QI project on decreasing blood usage. Today, we're going to wrap that up and move on to something new. We want to give a thank you, a big shout out to our amazing speakers that we had for this project. Kevin Brady, the Chief of Cardiac Surgery at St. Joseph's in Arizona. Amanda Ray, Advanced Practice Lead at the University of Maryland, St. Joseph's Medical Center. Melissa Williams, member of the Transfusion Task Force at Duke University Medical Center, and then Karen Singh, professor of anesthesiology at UVA Health. So we want to thank all of those speakers. They were amazing. I feel like we learned so much from them, and we really appreciate their participation in our quality series webinars. So some of the things that we learned, I think that the two most important things are the first block there and the last block. Decreasing blood usage is a culture change. I think that is so true when you're talking about trying to decrease the amount of blood products that you're giving. I know it used to be common practice to give 2 to 4 units of packed cells right out of the OR without a thought about it. But these days it needs to be more thoughtful, and that is truly changing the entire culture at your site. Also, decreasing blood usage is a multidisciplinary endeavor, and it touches all phases of operative care. I think we saw from all of our talks that were presented, there were interventions that could be implemented in the preoperative phase, the intraoperative phase, and also the postoperative phase. So it really is all encompassing and involves the whole heart team. Also, you must have good buy-in from your stakeholders. And to be most successful, you need a surgeon or physician champion. Going along with that, the surgical team must own the transfusion orders. I think what we heard about that is only the surgical team should be ordering or authorizing the giving of blood products. All members of the healthcare team must be aware of the goals, need to be aware that we're trying to decrease our blood usage, and be mindful of the fact that it really is better for our patients, and also review the data so that you can check your progress. I think it's helpful when everyone is aware of what's happening at your site. Then another key point, optimization of preoperative anemia and minimizing blood loss in the operating room. Those two things are super important in decreasing blood usage. And then again, another super important point that we learned is that all members of the healthcare team must be able to tolerate permissive anemia. You have to be able to be okay with a low hemoglobin and a stable patient before giving blood products. And then also from Dr. Brady, a final thought, even though blood conservation requires multidisciplinary collaboration, the journey typically starts with one person. And then you build on it from there. So I feel like a lot was learned, a lot was shared, and I really enjoyed all of the conversations we had around decreasing blood usage. All right, with that, we'll just review why do we focus on quality improvement? It's obvious that we want to improve quality for our patients, but what other reasons? So by offering this quality improvement series, we want to show the value of the database. Our database is valuable outside of just getting reports. It really does lead to increased quality of patient care and a better patient experience. We want you to be able to make your data actionable. You are important when you're abstracting the data. Your input is important, and being able to take that data that you abstract every single day and make it work to improve patient outcomes is tremendous for what we do for our patients. Also, being a part of a national team effort in improving patient outcomes is terrific, and it's awesome to work toward that effort together. So that is why we do what we do. With that, we're going to introduce our new QI series on decreasing postoperative renal failure. So we're going to just go over a few statistics. When I was researching this, I was kind of surprised at some of these. I knew that postoperative renal failure and AKI in cardiac surgery was a pretty big deal, but when you think about it in terms of patient outcomes and cost, it really is staggering, some of these numbers. So from a study in 2023 published in the Annals of Thoracic Surgery, up to 80% of cardiac surgery patients may have some degree of AKI associated with their procedure. And AKI increases the risk of morbidity after surgery and in-hospital mortality. Among postoperative CABG patients with elevated preoperative serum creatinine, 76% of those who developed stage 3 AKI required renal replacement therapy, of which 66% died within 30 days. That was a staggering number to me. So even patients with the mildest form of cardiac surgery-associated AKI and those with the lowest risk have higher rates of in-hospital mortality. Patients with postoperative AKI also have higher long-term mortality, with survival differences as much as 44% versus 63% for AKI and no AKI, respectively, at 10 years. So this difference between patients with and without postoperative AKI still exists even when there is complete renal recovery at the time of hospital discharge. So even if your patient recovers, they are still at risk in the long term for mortality from that event. An additional study revealed that prolonged episodes of AKI were associated with increased in-hospital mortality rates of 15.3% for AKI that lasts 7 days or greater, compared to 4.1% for AKI lasting 1 to 2 days. Then another study showed that patients who experienced early renal recovery following AKI had improved long-term survival, with the most important predictor of 1-year survival being the percentage reduction in creatinine within 24 hours of its peak. Patients experiencing AKI are not only at risk for mortality, but they're at risk for increased morbidity. They're more likely to develop sepsis and coagulopathy. They face an increased risk of requiring mechanical ventilation. And they also have elevated rates of other postoperative complications, including infection, prolonged ventilation, and cerebrovascular and cardiovascular events. Hansen and others determined that the 5-year risk of a combined cardiovascular outcome, including MI, heart failure, or stroke, was around 25% for patients experiencing postoperative AKI following cardiac surgery, compared to 12.1% for those without AKI. Then in another large single-center cohort study, they found that 79% of patients who developed AKI also experienced at least one additional postoperative complication after surgery. So in addition to mortality and morbidity, postoperative AKI contributes significantly to increased hospital length of stay, cost, and resource utilization. So in an early study, before there were consensus definitions of AKI, it was estimated that one episode of hospital-based AKI resulted in nearly $7,500 in excess cost, and that hospital-based AKI resulted in annual expenditures which exceed $10 billion. A newer study has found that postoperative AKA translates into longer ICU stays, higher readmission rates, and contributes up to $69,000 in additional cost per patient. And in total, this adds $5.4 to $24 billion in complication costs to the US healthcare system every year. That's just an enormous amount of cost. Then in a different study, cost averaged $37,000 for those with cardiac surgery-associated AKI compared to $18,000 in patients without it. And then again, ICU and overall hospital stays were longer, and they found that the cost rose in line with the severity of the AKI classification. These higher expenses were noted across multiple care areas, not only ICU, but medical supplies, laboratory, pharmacy, respiratory services, and et cetera. So as you can see, acute kidney injury, AKI, renal failure, they cause a bit of a problem for our patients. Here is a breakdown of the STS renal failure rate from the Harvest One benchmark report. So you can see the lowest rates of postoperative renal failure are for CABG, AVR, and mitral valve repair. The highest rates of postoperative renal failure are in our multi-valve plus CABG and our mitral valve replacement plus CABG. So if you think about all of your mitral valve replacements plus CABG, around 10% of those have an event of postoperative renal failure. So what do we want to accomplish with our decreasing postoperative renal failure project? So the plan, we want to nationally decrease postoperative renal failure in cardiac surgery patients over the next 12 to 24 months. What are we going to do? We're going to engage site leaders who've had success with decreasing renal failure to present their project on an upcoming webinar. We want to use the STS harvest reports and local data at your sites. You'll want to use those to implement processes to decrease the incident of postoperative renal failure. And STS will serve as a resource for education and support. We'll study by tracking our data during the period to measure progress, and at your site, you will track your data to measure your progress. Then our action items will be to review the data and evaluate and adjust the processes to facilitate improvement. To do all of that, we need you. We need your participation. So if you or someone at your site has been successful in implementing a QI project related to decreasing postoperative renal failure, you can reach out to me, Nancy, at nhoneycutt@sts.org. We would love to have you share with the group how you've been successful in your in your implementation of projects to reduce renal failure at your hospitals. All right, so we have time. We have lots of time actually for questions. So if you want to put those into the chat, or not into the chat, sorry, into the Q&A. getting all tongue-tied here. So we have
Nancy, great job on your presentation. This is Carol. I'm excited to see where this goes. I have a quick question. A quick question for you on the data. I put it in our chat, on our group chat, but I could just ask you. The data that you showed, it listed H1 2024 benchmark. Did you mean H1 2025?
I did, but it was
Okay.
it was for the column 2024 on the benchmark report. So
Oh, okay. I
I'll
got it.
update that slide. And yes, but it is from those numbers were from Harvest 1 2025 on the
Okay.
benchmark report.
But it was for data for 2024?
Correct.
Okay. The year-end data. Got it.
Yeah.
Thank
Sorry
you.
about
Thanks
that.
for clarifying. No, you're fine. I just wanted to make sure. I had a question. I'm gonna, there was a question in the data I see, but maybe it's being driven by my mitral valve procedures. If we look at that data, I'm just gonna clarify with our research center to make sure, come back with an answer on why the multi-valve plus CABG rate is so high.
Oh yeah, where do you see that one?
On your, if you go back to the, like the Excel sheet, what looks like came from an Excel sheet.
Oh, I thought you were looking in the Q&A.
No, it's my own question.
Oh, okay. I
That
need to get
one.
with the program today. Yeah. There we go.
So I was just going to get more clarity on that from our research center, why multi-valve and CABG was as high as it is.
I would think, just kind of anecdotally talking about that, the multi-valve plus CABG, those patients, I think, are more at risk. They have more comorbidities, is a reason I would believe, but the research center obviously would know better.
No, it's a good point. And the multi-valve alone is 7.93%. That's interesting.
It kind of doubles with CABG, which is interesting.
Yeah.
I wonder if it has to do with the amount of time in the OR, the amount of time on pump.
And likely the CABG patients probably underwent maybe a cath right before the procedure or something.
Yeah.
Okay, I got it.
Too.
Thank you. Yeah, and I guess if there are not clinical people on these calls and you have questions about anything that's talked about, feel free to speak up. I'm going to ask your question. Don't be shy. So we can explain or have somebody explain it so you can understand how it all works. Because I think once you understand how renal function works, when you look at procedures and you look at preoperative testing and procedures, realizing how that all fits together in the post-operative course of the patient, I think helps paint a picture of why it's important. We look at the whole patient's whole story. So don't be shy. I'm going to go on mute now.
Oh no, don't go on mute. I enjoy your company. Let's see.
Okay, I'll unmute.
Okay, so we'll go ahead and go through some of these other questions that we have. So Pamela is asking if the AQO virtual option is the AQO virtual option going to be live so we can see the same information as those that are going? Last year virtual was at a later date. So the virtual content will be, there'll be some on-demand content on the virtual platform, and then the talks or the presentations at AQO in person will be recorded and will be made available at a later date. And then I believe we are still having a webinar after that where you will be able to ask questions. Did I get that right?
Mhm. Yeah, that sounds good. I think you got it right, Nancy.
All right. So Rochelle says, interestingly, we have really low rates of post-op AKI at our facility. I think our population is low risk overall. That could be true, Rochelle, but it could be that you're doing things to prevent AKI to begin with, maybe things preoperatively or in the OR. And if so, we would all be interested to know what they are. Thank you, Mary. I'm glad you found that information informative. Let's see. Kathy wants to see slide 14 again. Go back. This is postoperative CABG patients with elevated creatinine. 76% of that, this is elevated creatinine preoperatively. 76% of those developed stage 3 AKI and required some sort of renal replacement therapy. And of those patients, 66% of those died within 30 days.
That's helpful, Nancy. I wonder, did we go through what AKI is and renal failure, the differences between kidney injury, kidney failure, what we measure in the database, looking at postoperative kidney failure, we use what's called the rifle criteria. There's more information in the training manual. In that criteria, the F in rifle lays out what the definition for failure is. And that's what STS uses. Prior to the patient going into renal failure, there's different stages of insufficiency or injury that lead up to the patient going into full stage failure. And then from failure, you can go into chronic renal failure, which is something that the patients don't usually recover well from. So maybe we could go maybe in one of the upcoming webinars, or we have time now, we could talk more about injury or failure. I don't want people to assume that there's no difference between them. And actually what we're seeing here is there's different stages of AKI. Stage 3 acute kidney injury, or AKI, is the stage right before the patient goes into renal failure. So it's a more severe stage.
Correct. And Heather also kind of asked about that. Could we define that better? Or define it, cardiac surgery associated AKI. We can go over that in a future webinar as well. But acute kidney injury is a precursor to postoperative renal failure, which is what we track in the database. And it stands to reason that if we're trying to prevent acute kidney injury or AKI, that we will prevent postoperative renal failure in the end. So doing everything we can to prevent acute kidney injury before it develops into postoperative renal failure is kind of the direction I see this project heading.
That's great.
Nora is asking about sources. Yes, there are sources at the end of the slide presentation. And these slides will be posted on the website. For you
Got your
guys to
reference
take a
slide.
look.
Look at you, Nancy.
I
Good job.
know. Yeah, and so Valerie asked to see references as well. So these sources will be posted. in the slides on the website for you guys. Then Hannah points out that I think she's talking about the reason multi-valve
Yeah.
and multi-valve cabbage rates are elevated is because of pump time and morbidity prior to surgery.
Yeah, and I also, one thing I just heard back from Robert, our VP of Research, he said also look at the transfusion rate. So blood
Mhm.
transfusion plays a role in acute kidney injury as well.
How appropriate that we follow that project with this one.
Good planning, Nancy.
Tim is asking if large volume centers could, excuse me, provide their pre-procedure process for working with nephrology. If any of you on the webinar have any information about that, that would help Kim and the rest of us, that would be great if you could share. Because I do believe it is a process working with nephrology, getting their input into how to manage the patients is key to success. Rochelle says they have found AKI increases with heart failure patients and PCI. That's a good point. Hey, Gia has a question about the beta blocker project. Are we still continuing with this?
Yeah, for right now, hi Gia, for right now, we're continuing with it. The research center is looking at the data this summer, which will include data through harvest too. If it's taking up too much of your time, we're hoping that we have enough cases now. If it's taking up too much of your time, we do greatly appreciate every site that has volunteered to collect that. If you do not have the resources to continue, you can consider discontinuing collecting the data. If you do have the resources, we'd still like you to collect the data until we officially say you don't need to do that. The other thing about what's interesting, and we'll probably get into this in some of our other webinars when sites who have a renal failure quality improvement project ongoing or that have performed one come and present to us. One thing I learned as a nursing, and I'm sure other ICU nurses learn this as well, is the sooner you get your patient up out of bed and you start getting their blood moving and working on their perfusing their organs, you could get them off of things like Levophed or the vaso medications, and you get them up walking, get them perfusing, you get them off those medicines, and their kidneys start working. You get the blood pumping to them. So early ambulation is often key to helping with these types of issues. And I just want to throw that out there in case it's never said, because I learned that a lot. It was a big thing for me to see. It was pretty neat. Once you get those patients up, you could get them off the Levophed.
I think that's
Is that still a drug that's still being used? Sorry.
Levophed.
Yeah, just kidding.
I think we still use Levophed. But I also, to your point about the early ambulation, that is so important for everything post-operatively. And it's so basic. But if you get your patients moving, it improves every system, every body system. It improves your respiratory system, your circulatory, renal. It really does improve everything, gets everything moving. Then, like you said, you can get off those vasoactive medications that are clamping down your blood flow. I think it's basic, but it did need to be said.
It's so basic, and it's not, you get scared when you're taking care. And I know most of us are not bedside nurses any longer, but it's a thing that we can share with our colleagues who are at the bedside is even, you get scared when you see your patients with low pressures and you have them on vasoactive drugs, and the vasoactive drugs right now are keeping their pressures above, 60. But even doing the motion in the bed and getting their blood moving in the bed before you stand them up, or even just sitting them on the bed, doing leg pumps or leg stretches, arm stretches, really getting their blood moving the best they can. It doesn't have to be walking around the nurse's station or walking down the hallway to start, but at least get something going. Because those patients, the renal function can decrease so quickly in those patients that are bedbound. So those are things because I was nervous. I was always really nervous to get my patients up who were um, who had low pressures and were dependent on the vasoactive drugs. We just got to get over that, I think, as a nurse. Get them moving. Okay, I'll be quiet now. I'll be quiet.
All right, so Janet has made a comment. They also review their cases through PSI 10, but those cases are excluded if it's an emergent procedure. Is this something that we would consider?
Excluding emergent from procedures from postoperative renal failure?
Or, yeah,
I don't think so.
yeah, I don't think so. I think that we would, we want to know if our patients are having postoperative events of any kind, whether they're elective, urgent, or emergent.
Yeah. Now, for aorta patients, I think those patients might be a little bit different just because of
Mm.
the amount of blood flow that the emergent cases can lose through a dissection or a ruptured aneurysm. So those patients might be excluded. And I think they might be excluded from the model. We haven't, from the risk model, we haven't quite got there yet. But for procedures like CABG or valve plus CABG, they will not be excluded.
All right, and Rochelle is commenting about her her low renal failure rates and low risk patients. She says she can't think of anything specific that they do at their site. So
It might be already embedded in your culture.
yeah, yeah. Or it's those awesome ICU nurses getting them up,
Yeah.
moving them around. Thank you, Rochelle. Thank you, Heather. I'm glad you found this helpful. And Natalia, are there any protocols similar to the ones that
Prior to
she's had
entering the
for
cath
cath
lab.
procedures? Yeah. It would be great if anyone has access to their protocols that they do use for their cath procedures, or any other protocols or order sets that they can share. If you can share those with us, and we can
Yeah,
talk about those on a webinar, I think that would be helpful.
yeah, I'm certain that there are, right? Looking at postoperative urine output,
Mm-hmm.
with any chest tube output.
We do recommend, or it is recommended, or it's best practice to discontinue ACE inhibitors prior to surgery. Those types of things. Okay, so Nicole is asking, are the current metrics collected used to determine if a patient has an AKI entering into the OR? We mark if a patient is on dialysis pre-op, but not specifically if they have AKI. So curious if that's being considered for post-op complications. So we aren't, the data that we're collecting is not determining if there's AKI as the patient's entering the operating room. And we aren't currently capturing AKI. We're capturing renal failure. So checking that the patient is on dialysis preoperatively excludes the patient from being in the postoperative renal failure postoperative event, as does a creatinine greater than 4.
Is for the AKI criteria, Nancy, because we do collect a preoperative creatinine level. Is there AKI criteria that just looks at creatinine level? Or is AKI
Isn't that
criteria?
part of the rifle criteria though for risk?
Yeah.
Yeah.
I don't know that we
Yeah.
don't look at a baseline creatinine to tell if there's a difference between baseline and the preoperative creatinine level to determine AKI staging. The only thing that looking at the baseline or looking at the preoperative creatinine level, you could determine the only thing you could determine is stage 3 or a level of a creatinine of 4.0, which is considered failure. Okay.
Yeah, and then Rochelle made a comment, the pre-op creatinine would indicate if a patient meets for kidney failure.
Yeah, that's it. Not insufficiency
Yeah.
though,
Yeah,
or injury. And we don't collect GFR.
right. Let's see, Beth Canali, we had asked about nephrology, the process with working with nephrology, and she says they don't consult nephrology unless there is renal injury. So I guess at your center, Beth, the surgeons manage AKI and renal failure, or until there's failure. Okay, the patient who is less severe is more able to get up faster and mobilize, so less AKI. So another comment from Beth. Natalia, if a patient is on hemodialysis pre-op, do they get excluded from post-op AKI? So they would be excluded. So in the STS, we don't collect AKI specifically, we collect renal failure. But if a patient is on dialysis preoperatively, they are excluded from postoperative renal failure. And then Judy has a comment about referrals to nephrology. So they referred to nephrology pre-op if the GFR was less than 30, but ended up stopping. It added too much workload. It's helpful, if nothing else, because it made them think about protecting kidneys post-op. And then Judy commented also that it's interesting our patients with normal GFRs that end up with renal failure. And then she says it only takes like 3 or 4 events, renal failure events, to make your O to E greater than 1. And Nicole says she sees a lot of documentation of patients having stage 3 AKI, but their creatinine isn't significantly elevated pre-op. She was just curious if we're able to delineate the patients rolling into the OR with that diagnosis already in place, or if it's truly new and related to the procedure. So we're currently not identifying that AKI. Judy's asking, are patients with dissections included in the risk model, the aorta risk model? I believe we'll only be looking at aneurysms.
I had my
in the
thing
aorta
muted.
risk
You're right,
model.
Nancy. It's just aneurysms.
Yeah.
But I think we remove emergent. We'll have to double check. Don't quote me on that. But I think there's an exclusion in there for non-elective cases.
All right. And Michelle says, thank you for the presentation. Why does STS not track GFR?
I think we were concerned about data burden, and we felt the surgeons felt that they could get enough information from the preoperative creatinine and preoperative dialysis question.
And then from Miko, is there a consideration to look at history of chronic kidney disease 4 and 5 and not just dialysis as pre-op criteria for exemption to post-op renal failure? I am not aware that that has been considered.
Yeah, no, it hasn't, not in the risk model bill. It's certainly something we could pass on. I don't know how, I guess we would have to, but I would have to better understand how do we define CKD 4 and 5 outside of the use of outside of dialysis.
And Hannah is just pointing out that risk factors impact your O to E. If all of your patients are low risk, your O to E will be higher. All right. Well, we've come to the end of our questions.
Great webinar, Nancy. Good job.
Thank you, thank you, thank you. Oh, we have one more. Miko's noticed a trend of patients CKD 4 or 5 not on dialysis with high potential for post-op renal failure requiring dialysis.
Yeah, that's tricky. And I think we have, I don't know if they're getting a round of dialysis before they go into the OR or not, Miko, but I think we have clarification in the training manual on those patients. I think it's good to point out. And I'm not sure how, when we look at CKD 4 or 5, we're talking about complete kidney loss and end-stage renal disease. So it's something we can certainly bring to our surgeons and to our research center.
All right.
All right, good job, Nancy. Thanks everybody for joining.
Thanks for joining.
Great
We'll
job,
see you on our
Yeah,
thank you. We'll see you on our next monthly webinar, which will be on a Thursday rather than a Wednesday, August 14th.
Woohoo!
3 Eastern, 2 Central.
Great
1
job.
and 12
Thanks
Pacific.
everybody. Have a good rest of the day.
Thank you. Have a good
Okay.
day.
Bye.